invite Dr. Ulhas Pandurangi, Director Electrophysiology and Heart Failure at the Madras Medical Mission in Chennai. This afternoon for the next 15 minutes, Dr. Pandurangi would be delving on devices in heart failure. What's new?
This is something to do with the devices in heart failure, and I concentrate on the cardiac resynchronization therapy. We all know that the cardiac resynchronization therapy has time and again come to our rescue when you are dealing with some desperate subsets of congestive heart failure patients. And over a period of 15 years, it has been considered now to be established and a cost-effective therapy, at least in the Western countries, and there has been an unanimous concurrence regarding it being very useful in some subset of patients with congestive heart failure. It has been endorsed by major heart failure specialist societies. There has occurred some change as compared to the guidelines which have been published, say for example in 2012. The society still recommend class 1, they recommended by 2012, and they given the designation of class 1A indication in those patients with congestive heart failure, really symptomatic, class 3 or class 4. And they have one special characteristic, and that is they have had all ejection fraction 35% or low, and in addition to wide QRS and in sinus rhythm. In the last 2-3 years, there has been again further accumulation of the way the patients behave with respect to the implantation of the CRT, and some significant changes have taken place, and the observations and randomized controlled trials have helped to further modify the recommendations, and that is the topic of my talk. Over the years, it has been seen that not all the patients with that subset of congestive heart failure patients with that subset of ejection fraction and that width of QRS have uniformly responded to the cardiac resynchronized therapy. It has been found that if they have a wider QRS, and that is specifically like that of a typical left bundle branch block pattern, and if they have this non-ischemic etiology as a cause of cardiomyopathy, they seem to be at the highest level of the responder rate, and they describe them as good responder, and some of them belong to the super responder category. The same patients of congestive heart failure, ejection fraction less than 35%, but if they have an ischemic etiology, and if their width of the QRS is not like that of a typical left bundle branch block, they seem to have responded much less. So all those observations and the registries, and most importantly few of the randomized controlled trials have been so very influential that in the last 2 years we have had at least 3 major revisions with respect to the guidelines when it comes to the implantation of resynchronization therapy by pacing. The current guidelines suggest that there is a subset of patients whom we indiscriminately had implanted the device and we should stop. And what is that? When you consider a CRT, your patient needs to be having real dysynchrony which is manifest, albeit surrogately, on the basis of the surface ECG with the QRS 150 milliseconds or more. This is a major revision. Earlier, it was just about 120 milliseconds, and the pattern of left bundle branch block was not really required. It was just the wide QRS. Notice there has been a significant change here. In addition to the type of the widening of the QRS, it is something to do with the symptomatic status. It's class 2. Earlier, that was recommended for patients who are really more symptomatic, class 3, class 4, and ambulatory class 4. And some people even they suggested after class 4, and if there is an intubation period is over, consider. But presently, it is less symptomatic patients and also more sick patients should be considered. It is not only 120. Should be 150 milliseconds. I think logically also it sounds to be correct, because more the width of the QRS and more it is looking like left bundle branch block, a left ventricular pacing might actually benefit more. So that is the major revision, and there are a few more revisions here. 120 and above, 120 and above, typical LBBB is class 1A, but if it is 120 to 150, less than 35%, it becomes 1B. The emphasis is more on the type of wide QRS. If it is non-LBBB pattern, and if it is only more than 150 milliseconds, then there is any value in thinking about the CRT. So it is just not the width of the QRS, it is the pattern of the QRS and its resemblance to the typicality of left bundle branch block. There has been an emphasis on recruiting more and more patients who are less and less sick. And there have been several trials. And those randomized controlled trials look at the efficacy of cardiac resynchronization therapy, because they believed there can be certain mechanisms which may benefit them. And what are those mechanisms? They believed that at the earlier stage of an intervention will promote positive remodeling. It would minimize dyssynchrony at that stage, and further does not permit negative remodeling. Most importantly, there may be some sets of patients who have got some degree of a AV dyssynchrony in the form of a prolonged PR interval, or maybe some arrhythmia. So bringing in an early CRT, not before, much before they become sick, or where the hypothesis proposed, and indeed, there were editorials written, and those editorials and the guidelines were based on 3 mega trials, each one of them recruiting more than 1,000 patients with wide QRS, left bundle branch block pattern with more than 150 milliseconds, all right, but then they were not sick. They were just about class 2, and the made it CRT included not only the less symptomatic patients, but it also included the patients with ejection fraction just less than 40%. They didn't think about real sick patients to be recruited. These 3 large trials, which were positive, made the guidelines to look into, to recommend for less sick patients. And who are they? It is NYHA class 2, ejection fraction 35%, and as I said, bundle branch block resembling left bundle and more than 150 milliseconds. NYHA class 2 is good enough. And that is class 1 indication. Who else? Patient may be having a very, very low ejection fraction, and just that they are used to that kind of a, ejection fraction, and then they are not symptomatic. So who are those? Ejection fraction less than 30%. They have got wide QRS, maybe in the sinus rhythm, but they are used to their life. They are hardly symptomatic, what we call class 1. So the current recommendations or the current guidelines include these heart failure patients who are hardly symptomatic. And indeed, they also fall into that part of the pyramid where the responder rate is highest. So this, I believe, is a major change with respect to the guidelines. There has been keen interest even looking at the dyssynchrony, mechanical dyssynchrony in those patients who have got electrical synchrony in the form of a narrow QRS. However, at least 2 large trials, one is the Rethink study trial and another one is a prospect trial which looked at heart failure patients with narrow QRS but echocardiographically proven dyssynchrony. What is its role? So this subset of patients, actually, the researchers really wanted to bring them into the umbrella of resynchronous therapy, but both the trials showed that it is not useful to think cardiac resynchronous therapy. So currently, there is more and more emphasis on the ECG criteria of dysynchrony and not necessarily guided by some imaging modalities, for example, echocardiography or some other imaging techniques. Recent guidelines have also focused on those patients who require permanent pacemaker implantation for reasons of AV blocks. Especially in the context that in a patient who requires a permanent pacemaker, and if he has got right ventricular pacing now and then his ejection fraction is lower, we all know that there are detrimental effects of right ventricular pacing, especially when the patient requires more often ventricular pacing support. There have been trials to look at how about thinking instead of a conventional permanent pacemaker, but go for a cardiac resynchronous therapy patients who have got low ejection fraction and an AV block and requiring permanent pacemaker. There are 3 trials, HOBE, PACE Combat and Block HF trial. Very small trials. Look at the numbers. There are less than about 50 patients in each trial, but they were very important because that they looked at that particular subset. In addition to these 3 trials, there were 3 more trials which also looked at those patients who have got preserved ventricular function, and because they believed that the right ventricular pacing may in future deteriorate the systolic function, so proactively they started looking at the utility of CRT in those patients with requirement for pacemaker and underlying normal ejection fractions. So the guidelines looked at them, and then now it is being considered as class 1B indication, especially in those patients who have got permanent pacemakers or ICD, and then they have pacemaker requirement, and then the pacing is too often. It is recommended that such patients be considered for upgradation from permanent pacemaker or just a defibrillator to the CRT or a CRT-D, because those trials have shown that converting in such a way improves the survival. If you really look at, or if you want to be really more active, well, you can also consider CRT in those patients who have got reduced ejection fraction de novo. So don't put in a pacemaker and wait for how do they behave, but straight away start putting in the CRT in those patients whom you think already there's an existing ventricular dysfunction and they are going to be pacemaker dependent. In them, to obviate the detrimental effects of right ventricular apical pacing, you go proactively for biventricular pacing. Few words about CRT-P and CRT-D. This is always a debatable issue. And there are no head-to-head trials because it's just not possible, and it is improbable that one such trial may come soon. However, the guidelines have become bolder in the last 2 years, and even though logically CRT-D should have an upper hand when it comes to the effect of CRT, the guidelines very recently have put this table up for all of us, and that is you consider CRT-P alone if you think your patient is suffering from a lot of comorbidities, cachexia, where survival is probably not really long. In that case, please don't make his survival prolonged painfully with the defibrillator shocks. So maybe the comorbidities, maybe your clinical judgment regarding the survival, you may pick up CRT-P over CRT-D. A few words about vagal nerve stimulation, which is a new thing. Which actually affects the vagal tone. There are Anthem trial. Our institute has been proactive in this, which has recruited presently about 7 patients. And recently, only a few days back, Nectar HF, again, which looked at vagal response, had shown some positive trends. So ladies and gentlemen, this is my last slide. I think over a period of time, we may end up in having such devices in case the research towards leadless pacemaker comes up, wherein there is no need for leads or no need for the batteries. That technology is there. But if that technology is not going to catch up, I believe our devices, which are CRT or a CRT-D, will have several elements. And it might look like this. It may have a biochemistry lab. It may have a drug store, which may release the drug intermittently according to its level, because there is a gadget inside this box which will measure, because it's a biochemistry lab. It has several of the leads, which not only is going to make dyssynchrony more synchronous, but it also has pacing at many places, including the vagal stimulation. So there may occur incorporation of these elements into the devices, and maybe by next year we'll have some more guidelines with respect to type of the device and the subset of the patients. Thank you.
Thank you, Dr. Pandurangi.
Any questions? I think there is one delegate who has a question.
Dr. Pandurangi, what is the role of a CRT now in intermittent atrial fibrillations?
Yeah, I heard you saying atrial fibrillation. Atrial fibrillation, the role of CRT. Is that
Less
right?
than 35% ejection fraction, NHYA 3 or 4, wide QRS complex more than 120 milliseconds, and the guy who's having an intermittent atrial fibrillation.
Right. The guidelines do not recommend strongly in any patients with atrial fibrillation for a CRT. They all fall in class 2 indications. You will have to manage them a little better and then consider for CRT. So that is the cue there. And what is it? These atrial fibrillation patients, if they continue to have erratic and a rapid ventricular response, the device would not be able to deliver maximal biventricular pacing. And hence, you will have to have a controlled and a regular ventricular rate during atrial fibrillation. So that is how we should achieve, by either drugs, which is rarely possible. And if you're really very desperate that this patient now indeed requires something more than what you have been doing, the best way to treat them is to ablate the AV node and then put in these devices. It gives an opportunity for us then to intermittently cardiovert them in case if you're not branded them as permanent atrial fibrillation. As long as you don't brand them, even in a persistent atrial fibrillation, it has been shown that intermittent cardioversion, by taking appropriate cautions regarding the anticoagulation part, it is shown that they may actually do really very well, and we should not be simply be discarding this atrial fibrillation group.
So will you please evaluate about this ablation therapy?
Don't mind, repeat the question.
Ablation therapy.
Ablation therapy
Yeah.
for
Atrial fibrillation.
atrial fibrillation.
Yes, yes.
Well, I think this is a little out of track, but the scope is there for an atrial fibrillation ablation in patients with CRT. But let me be very honest with you. I do not think in India the technology is available so much as to take care of post-CRT patients for ablation for atrial fibrillation. And the recurrence rates are so very high, and complication rates are not ignorable. So I believe atrial fibrillation ablation in the setting of CRT patients is probably can take place in some countries where reimbursement and the technology is widely available.
You mentioned about patients with LV dysfunction. When we give, if we have to give for AV block, dual chamber pacemaker, you said that the ejection fraction can drop. And in those patients, you should give a CRT. So which are the patients? You think it's patients who have old MI, or particularly who have weak muscle, or where you think even a little deterioration would cause worsening of the patient? So which patients are those subsets?
Yeah. See, your question cannot be addressed at this time because the trials which recommended the CRT as a proactive measure in patients who require AV pacemakers for the AV block and LV dysfunction, the data is not so very much where you can actually again look at, is it an ischemic cardiomyopathy patient or a non-ischemic cardiomyopathy patient? What is the age group, and whether they indeed had a revascularization, etc. You know, such things are presently not existing. The concept here is if your patient is going to be dependent on right ventricular apical or an alternative site pacing, and if you have a fear that this ejection fraction may deteriorate, at that stage, proactively you can put in a pacemaker. But let me insist that the guidelines do not recommend this strongly. This is at this point in time class 2 indication.
Okay, if there aren't any further questions, then we'll move ahead with the presentation ceremony. May I invite firstly Professor Vijay Lakshmi to please step forward and present memento to Professor Geeta Subramaniam.
You won't get this photo in any case. It will be kept here.
Okay, may I now invite Dr. Bhargav to please step forward along with Dr. Govind to kindly present memento to Dr. Ulhas Pandurangi. Thank you very much.